Okay, a couple of quick announcements. PA students, PAs, we will finish early today. I've already talked to Professor Perez. He will start when we're done. I'm going to tell him 15-minute break, and then you guys start early. So for anatomy, you start early. All we have is just a 30-question Kahoot. We'll go through it. We'll go through the wrong answers, kind of teach you a little bit how to study backwards. With just looking at exam questions, how you can study a bunch of different topics all at once. So we'll get that going as well. 30 questions, straightforward. You guys still want that live review Sunday night?
Yes.
Okay. I'll do it Sunday, 7 to 8:30. Same as last time. Anyone having trouble getting in? No issues? Okay. Okay, we'll get started. Yes. I'll post this Kahoot right afterwards, after class. It'll be posted. Okay. Okay, question number 1. Okay, what cells are responsible for hemostasis? So what's hemostasis? Blood clotting, stopping the blood. Okay, guys, I'll explain it all. You gotta be quiet. So, hemostasis, stopping the bleeding. White blood cells have nothing to do with stopping bleeding. Red blood cells have nothing to do with stopping bleeding. Lymphocytes are white blood cells, so they're the same answer. So if you see two answers that are the same, they can't be the answer. So already, if you don't know what hemostasis is, looking at lymphocytes and white blood cells, they should cancel out because they're the same thing. Red blood cells and platelets are the ones responsible for that. Okay, all the following cells are derived from that common myeloid line, except which one is not on the myeloid line? It's on the lymphoid line. Okay, so remember I said, if I put a word in there that we've never discussed before, it's probably not the answer. We've never talked about osteoclast before. They're only dealing with making bone. Okay, so it can't be that one. So, what are the two lines? There's myeloid and there's lymphoid. Lymphoid only has two things. Remember that one, and everything else is the myeloid line. So when you're studying, learn the easier way to remember things. The lymphoid line just has your B cells and your T cells, and I think there's one more in there. But the B cells make what? Plasma cells. And what are your plasma cells? All your antibodies. Okay, I didn't put a couple of steps in there because I want to make sure you start reading the whole slide, not just whatever's next. Okay. Which of the following hormones are responsible for making white blood cells? You guys can see the questions and answers on your things, right? It's all there, okay. Okay, erythropoietin is for what? Red blood cells. Leukopoietin, white, and then the thrombo is your platelets. Okay, which of the following blood types will have anti-B antibodies in the plasma floating around? Don't assume anything to these questions. I'm only asking you about the anti-B antibody. I'm not saying anti-AE. They don't assume that. I just said which one doesn't have or will have anti-B antibodies. Or only anti-B. Okay, I'll put it that way. Only anti-B. Okay? Type A. So, when it comes to these blood types, don't confuse the antigen, which is on the red blood cell, versus the antibody, which is going to attack those antigens. So make sure you clear all those up. What's the final step in hemostasis? This is going to trick some of you guys for reading it too fast. What must all clots do at the end? Break down. Okay? Fibrinolysis is the final step. You have to break up the clot. It can't stay there forever. So that is part of the clotting process, is the very, very end. Vasoconstriction is the first one that happens, remember? Okay, the next thing is the platelet plug. And there are 3 stages in that one. Make sure you know the 3 stages. And then we have our clot formation. In the clot formation, make sure you understand the intrinsic pathway and the extrinsic pathways. What are you testing for on each side? They're different for each side. So as you're reviewing, go through that way. Okay, what's the second phase of platelet function? So here you are now. We're in platelet function. What's the second one? Okay, activation. Whatever mnemonic you want to develop to remember the different phases, go ahead, but make sure you know the 3 in order. What test would be a good function of aspirin, or good indicator of aspirin function? PTINR will be a good function of what? Warfarin, Coumadin. PTT, heparin. Reticulocyte count. What does that tell us? Making new red blood cells. And if that reticulocyte count goes up, it means we're making a lot of new red blood cells. There's got to be a reason for that. Work backwards and find out why are they getting destroyed. And bleeding time is the one that you do for aspirin function. Why aspirin is good for bleeding time? What does aspirin affect? Platelets. PTINR and PTT is all coagulation, but the bleeding time is platelet function only. That's why there's a difference there. So bleeding time is looking at your platelets. Remember, they're going to stop the bleeding. They're the first thing to get in there. After hemostasis, platelet plug formation. We want to know how long time it takes for that platelet plug to form. The better you are with your aspirin, with the platelet clotting and activation, all that stuff, the slower or the faster that bleeding time will be. The weaker it is, the more aspirin you have on board, or Plavix, the longer your bleeding time is going to be. Okay, which of the following is correct with regards to flow? Is flow proportional to pressure and resistance, inverse proportional to pressure and resistance? Or which one is the combination? Okay, so the greater the resistance, the worse the flow. You're resisting the flow. Something is in the way. It's not going to get through. Proportional to pressure. That should be pressure gradient. I'm sorry. So the bigger the difference in pressure, the better the flow is. So I apologize for that one. But talking about the pressure gradients. So we talk about pressure gradient and flow through the systemic circulation. What are the 2 points that we look at? To look at pressure in the systemic circulation is the difference between what 2 points develops this pressure gradient flow. Left ventricle going all the way back to the right atrium. Pulmonary is the opposite. Right ventricle to left atrium. That tells you your pulmonary flow. How is calcium put back into the SR? I said SR only. I didn't say out of the cell. Read the questions. So the sodium, potassium, ATPase pump, does that have anything to do with calcium really? No. Okay, the sodium calcium exchanger puts it outside the cell. The calcium ATPase pump puts it into the SR. Okay, so that's the difference between those two exchangers or the pump. One goes outside the sodium calcium exchanger. Calcium ATPase pump gets it back into the SR. Okay, what describes the action potential of the SA node? So this is a rhythmic cell or a muscle cell? Okay, so the depolarization rate. Okay, the depolarization rate is how many times is it going to depolarize in 1 minute, which is your intrinsic heart rate. For the SA node, what is the intrinsic rate going to be for the depolarization rate for the SA node? 100 depolarizations per minute. We know because of what type of coupling that we have? excitation, contraction, coupling, that if you have a P wave or a QRS wave or some excitation, we know there's going to be a contraction the following. So we call it beats per minute because it's going to be a beat, but it is the SA node depolarizing at a fast rate that controls the entire heart. The second part is the speed of the action potential. So remember the SA node, these autorhythmic cells, what kind of wave did they make? Was it straight up and down, or was it more like a sine wave almost? Sine wave. I don't think I can draw on top of this. The rate to get to the top, so that QRS complex or the ventricular myocyte depolarizes and it goes straight up, right up and down. That's a fast action potential. It got all the way to the top instantaneously. The SA node takes a little bit of time to get to the top of the action potential. So the autorhythmic cells, the SA node, AV node, have fast rates of depolarization, but a slow action potential. Why is it important that the autorhythmic cells have a slower action potential? Well, we're slowing what are we doing with the top part of the heart? What are they supposed to be doing while the bottom part is doing its own thing? Filling. So we need the slower action potential so that we don't have filling problems. Remember, the whole cardiac cycle is a timed event. If you're at 60 beats per minute, everything, the P wave, QRS, T wave, all the contraction things that we went over, all that Wigger's diagram, all those things have to happen in 1 second as well. So keep that in mind when you're studying. Everything has to happen in 1 second. If your heart rate goes faster, that means you have less time in each area. Causes problems later on. Bless you. Okay. What wave is represented by ventricular repolarization? So which wave on the EKG is ventricular repolarization? Did we ever go over a U wave? No. Does it exist? Yes, it does. It does, but we never went over it, so I'm not going to test you on it, but it is real. Okay, this is the T wave. The T wave is ventricular repolarization. What is the P wave? Atrial depolarization. What's the QRS complex? Ventricular depolarization. Very good. What electrical activity directly comes before ventricular relaxation? So ventricular relaxation is a mechanical event. When the heart relaxes, what has to happen right before it? This is also going to be represented in your Wigger's diagram. So if you go from the top, ventricular, the isometric relaxation, isovolumic relaxation, follow all the way down. The T wave. Okay, the T wave, that is ventricular repolarization. It's resetting the heart, going back to rest. So for ventricular relaxation, it's the T wave has to happen first. What heart sound is the AV valves closing, your atrioventricular valves? Okay, very good. This is your S1. S2 is what? Your aortic pulmonic valves. S3, what does an S3 mean? That's what it sounds like. What does it mean? It's a murmur, yes. What is it? You don't know? You were right. Well, yeah, but what does it mean when you have an S3 sound? Someone's saying over here, I think. Less compliance with the heart. And S3 means the heart is very stiff. Stiff hearts are less compliant. They don't work very well. So when that blood hits the ventricle from filling, because now S2 is done, now we're in diastole, which is filling, the blood's going to fall from the atrium into the ventricle. When you have compliance, it's going to expand and accept that bolus of blood. But when the heart becomes less compliant, it can't do that, and you get a sound of the blood hitting the wall. And that's what S3 is. What is S4? Atrial kick. The very end there, right? It makes sense that the S4 will be the atrial kick. What is going to happen at S1? What closes? AV valve. So the mitral valve is going to close in a second. Well, less than that. I'm being exaggerating, but you know what I'm saying. So that atrial kick is going to get that last little bit of blood into the ventricle before the mitral valve closes. That's why the S4 is right before S1. It's that atrial kick, that last little bit of blood right before that valve closes. So again, you see how now you're studying 4 topics just with one question? If I can ask what is the sound is the aortic valve closing? The same question, same answers, you just what's the right one? So that's how you study more effectively when you review questions. Okay, what happens at the end of isovolumic relaxation? So, isovolumic relaxation, what's happening to the pressure in the ventricle? Decreasing. And it's going to go lower and lower and lower until it becomes lower than what pressure? Atrial pressure. So at the very end of isovolumic relaxation, the mitral valve is going to open because we start filling again. Okay, so that's what happens at the end of isovolumic relaxation. Okay. Okay, which of the following is a way to decrease stroke volume? Okay, if I increase the preload, what's going to happen to my end diastolic volume? Increases. If end diastolic volume goes up, what happens to your stroke volume? Goes up. And what happens to cardiac output? Goes up. Increased contractility. If the heart is squeezing harder, what's going to happen to your stroke volume? Goes up. What happens to your cardiac output? Goes up. Decreased TPR. What does TPR mean? Total peripheral resistance. You may also see it as systemic vascular resistance, SVR. They mean the same thing pretty much. So if I decrease TPR, what is that going to do to my afterload? Decreases my afterload if I decrease the total peripheral resistance. If I decrease my afterload, what happens to my stroke volume? Goes up. What happens to your cardiac output? Goes up. So now we're left with the last answer. If I increase the stroke volume, what happens? If I increase afterload, you increase afterload, what happens to your stroke volume now? It decreases. It goes down. Therefore, what happens to your cardiac output? Decreases as well. So start remembering these properties as well with afterload, preload, contractility with regards to their effects on stroke volume. Afterload is the only one that's opposite. Preload and contractility are proportional. You increase stroke preload, you increase stroke volume. Increase contractility, increase stroke volume. Only afterload is the one that's opposite. Okay, where is the site of greatest resistance developed? Which one has the greatest surface area? Capillaries. Which one are resistance vessels? Arteries, the aorta is a great resistance. Venules, those are capacitance vessels. Okay, they hold on to blood. But the resistance is developed in the arterioles. Yes?
What did you say about the aorta?
It's a resistance vessel. It provides resistance. It can withstand, and then it recoils, so it has like a resistance, they call it. It can also withstand the high pressures, too. Okay, which of the following is a correct determinant of your diastolic blood pressure? Which one of these is going to affect your diastolic blood pressure? Okay. If you increase the vascular resistance, if I increase vascular resistance, how do I do that? What do I have to do to that vessel? Constrict it. So if I constrict the vessel, what happens to the pressure inside of it? Goes up. Everything goes up. Diastolic goes up too because the resting pressure is going to be higher because of the increased vascular resistance. Faster heart rate lowers the DBP? No, fast heart rate increases the diastolic blood pressure. And therefore, a slow heart rate will lower the diastolic blood pressure. So the red and the green ones were just opposite, but they were both not true. High vasoconstriction decreases DBP, which is just the opposite of the red one. Okay? Any questions about that one? That was a thinking one, yes.
Inversely proportional to flow, then why would it increase the blood pressure?
Because the diastolic pressure is when nothing's happening with the heart. The heart's resting.
Oh, okay.
So there's just a steady pressure in the system. It's like pipes in the house for your sink. There's water in the pipes all the time that provides a pressure in your plumbing. So when you turn on the faucet, there's water comes out. If you didn't have any water in there, you turn it on and nothing would happen. There's no pressure there. So that's what diastolic pressure is. It's just pressure in your house lines, your plumbing through the whole system. Okay, which of the following scenarios are correct regarding venous return? So blood coming back to the heart. High right atrial pressure will increase venous return. High total peripheral resistance will increase venous return. Low blood volume will decrease venous return. Or a low TPR will lower the venous return. Having a high right atrial pressure, what does that do to our pressure gradient flow from left ventricle to the right atrium? Decreases it. So that can't be the answer. High right atrial pressure decreases venous return, doesn't increase it. High TPR increases venous return. That's high total peripheral resistance, nothing to do it's a vascular problem, not on that end. Low TPR lowers venous return. Those are just opposites. Low blood volume, you have less volume in the system, less coming back to the heart. So that's how you decrease venous return. You just have a hemorrhage somewhere and you're losing blood, less blood will come back. What is the effect of norepinephrine on alpha receptors? Where are the alpha receptors found? That's your first thing you got to figure out. Where are the alphas? Are the alphas in the heart or are they in the vasculature? Alphas are in the vasculature. Okay, make sure you understand. Betas are in the heart. The alphas are in the vasculature. So the alpha receptor in the vasculature, when norepinephrine comes out, is going to cause vasoconstriction. That's how we get shunting of blood to areas that need it. So, increase heart rate. Will norepinephrine increase your heart rate? Yes. What does it have to bind to? Beta receptors, not the alphas. Increase contractility. Is that an alpha or a beta? Beta receptor will increase contractility. Contractility is a heart property. It's not a vascular property. Vasodilation in the skeletal muscle beds. What would the question have to ask for to that answer to be true? Epinephrine. Okay? Epinephrine will cause the vascular muscle beds to dilate so that you have more blood going to your muscles in a fight or flight. Yes?
So if it said beta, could it be the heart rate and contraction?
Well, I would have to change the answers, but yes. Yes. If it was beta, it would be increased heart rate and increased contractility. That's the role for the beta receptors on the heart. Alphas are in the vasculature. Low protein in the plasma will cause what condition? So protein, what kind of pressure does protein exert? Protein. Protein. What kind of pressure? Oncotic pressure. Proteins develop the oncotic pressure. The oncotic pressure, is that the push or the suck? Suck. Okay? Now, whenever you're dealing with a question about protein in the blood, it's going to wind up talking about some sort of edema formation because protein in the blood drives the oncotic pressure. Should there be any oncotic pressure in the interstitial space? No, it should be zero. We should have all the protein in the blood. That provides the suck, to suck the fluid back in. It opposes the filtration, bringing fluid back in on the venule side of that capillary. So anything with protein is going to have to do with something to do with plasma, edema formation, blood volume, something's going on with the protein. So I say here we have low protein in the plasma. So our oncotic pressure in the capillary was 15, now it's going to go to like 10 or 5. So we're lowering that pressure, we're lowering the oncotic pressure in the capillary versus the interstitial space. Less oncotic pressure, less suck, therefore where's the fluid going to stay? In the interstitial space, causing edema to form. Okay, so whenever you hear anything about protein, think edema, oncotic pressure. What is going on with this protein? Where is the protein? Is it in the capillary or is it in the interstitial space? Where is it? And just figure it out that way. Okay, the amount of maximal air inhaled above a regular breath. So what do we call regular breathing? Tidal volume. So what is the amount of air above tidal volume that you can breathe in? Now, remember when you are studying this section, volumes are just one part, capacities are volumes added together. In the question, I asked the amount of air above a regular breath. So do we include the tidal volume here or no? We don't include it. I'm asking everything above the tidal volume, which is our inspiratory reserve volume. If the question said the amount of maximal air inhaled with your normal breathing, now the answer becomes inspiratory capacity, because it's the amount of air we can breathe in with our normal tidal breath plus all the extra air we can get into our lungs. So capacities are two volumes added together. Tidal volume we talked about was just our normal breathing. What are you doing at rest? Vital capacity. What is vital capacity? What does vital mean? Life. So it's all the air that we use for breathing in life. So what 3 volumes does that include? IRV, TV, tidal volume, and your expiratory reserve volume. All 3 of those volumes is your vital capacity. What other volume have we not talked about that's also there? Residual volume. That's the amount of air in the lungs that we don't exchange. It just doesn't, we have to have some air in the lungs. If I wanted to include my residual volume, what is that? If I add our residual volume to your vital capacity, what is that new capacity you get now? Total lung capacity. So TLC includes all the volumes, including residual volume. Vital capacity does not include the residual volume. Okay. What is the most important muscle for expiration at rest? What's the important part of this question? At rest. Okay. When you are passively breathing at rest, inspiration, yes, the diaphragm, but expiration is passive. It's just your chest wall collapsing back to its normal position, provides enough force for you to exhale the air. If the question said with exercise, what's the answer now? Yes, so make sure you know those ones. Okay, they cause all the side splints. Okay, when you're sleeping, what part of your brain controls your breathing? Okay, why did I have to include sleeping in this question? It's involuntary. Okay, if it's involuntary, it's the brainstem that controls your respiration rate. If I said you're doing an exam on a patient and you tell the patient to take a big deep breath in, what's controlling that? Cortex, because it's all voluntary motor control. Through what nerve? Phrenic nerve, right? Phrenic, diaphragm. Vagus is what? Autonomic. We can't control a vagus nerve. Now, pulmonary vascular resistance. As cardiac output increases, what happens to pulmonary vascular resistance? So think about exercising. Your cardiac output's going up. You're running away from a bear. What happens to your pulmonary vascular resistance? It's not a trick question. Okay. Right now, you are all at rest. What part of your lung is actually being perfused? The bottom, the base, right? Because of gravity. We don't need anything else, zones, the other zones, because we're not exercising. We're not doing anything. We don't need the extra blood. We don't need the perfusion for ventilation. There's nothing there. As cardiac output goes up, we're exercising. More blood is going through the system, which is going through the pulmonary system too. So more blood is going to perfuse, and they're going to recruit more capillaries. Remember the recruitment. As we're going up into the second zone, the middle zone, we're going to recruit all these capillaries to open up wide. You see how we're adding more capillaries, which adds more surface area to diffuse out all that pressure. And that's what allows pulmonary vascular resistance to drop, because we're recruiting more capillaries in the pulmonary vasculature, which is going to lower the pressure. Because of that graph that talks about the little smiley face, the U, as you go different parts, what happens to vascular resistance? Yeah. I'll answer that question after this one, though. I don't want to take away. Well, here's another one talking about the same thing. So, which lung zone has the highest ventilation with no perfusion? Okay, so you had really a 50-50 chance on this one if you didn't know the numbers. It was, the top or the bottom, so zone 1 or 3. So we talk about ventilation. What are we talking about? Air moving. Perfusion is talking about what? Blood perfusing that tissue. What part of the lungs have all the ventilation but no blood? The apices of the heart, which is zone 1. So zone 1 at the top, 2 is in the middle, 3 is the base. So zone 3 is the most perfused because you're all upright and gravity is there. What was your question you had before? It's higher, actually, because of less capillaries. We only have that one zone being perfused, so that's where the pressure is going. So the pressure is a little bit higher, but as you start exercising, it goes down. Okay. Increasing body temperature will have what effect on the hemoglobin's affinity for oxygen? So affinity. Okay. Don't pick the green one, please. Don't pick the green one. Okay, let's walk this one through. First of all, what does affinity mean? How tight it's going to love that molecule and hang on to it. When we increase our body temperature, let's go back, make it simple as possible, go back to exercise. You've all exercised, you all feel your body temperature going up. When you're exercising, what do you want to get the most oxygen? Your muscles. So it makes sense that if you increase your body temperature, it makes unloading of the oxygen easier on your tissues. So you give oxygen freely to your muscles that needs it for energy. So when your body temperature goes up, the affinity for hemoglobin and oxygen goes down to make offloading the oxygen easier. If it was too tightly bound, it wouldn't release the oxygen. That's why we talk about if you decrease body temperature, like you get stuck in a frozen lake, you're going to grab onto all that oxygen and hold on to it because it increases the affinity for oxygen when you decrease your body temperature. So you hold on to it more easier and you load it easier in the lungs. So think about that with affinity. Where is it happening? Why do I want oxygen to get kicked off here? Why do I want it to be bound here? Think about, am I at the lungs or am I at the tissue? Think what makes sense. Carbon dioxide, I want that to be bound easily at the tissues and offloaded at the lungs so I can exhale all of that. If the opposite was true, you couldn't get rid of your CO2. Okay, where does the chloride shift occur? In the tissues or the lungs? Where does the chloride shift occur? Because remember, we have a reverse chloride shift. And where does each one occur? What other ion is being replaced by the chloride in this chloride shift? Bicarb. Bicarb. Remember, we have CO2 as a gas. We have to be able to get it dissolved in the blood and then have it be remade as a gas later on. Bicarb is a great way to do all that. So the chloride shift occurs at the level of the tissues, and the reverse chloride shift happens at the level of the lungs. Okay, so make sure you get those straightened out. Okay, what is a response to high altitude that takes weeks to develop? So remember, there's an intermediate, there's a few days, and then there's the long weeks one, which happens after weeks. So two of these are the same answer, just opposite, so they can't be the answer, right? So either like, does it increase or decrease unloading of O2? Okay. What is the first response that happens to altitude? You get off the plane with the first hours. Increased loading of O2 in the lungs, so you load up more in the lungs. After a few days, then we get increased unloading of O2 in the tissue. We can get it off the red blood cells easier to our working muscles. That's an intermediate response. Finally, the one that takes weeks to occur is the EPO, which is a hormone. They take a lot of time to develop. They take a long time to have an effect. So that's why it takes weeks to have EPO. What is EPO going to do for this person in altitude? More red blood cells. More red blood cells is basically more trucks to carry more oxygen. And that's the goal for all those. Okay, two more. Okay, what are the pressure gradients developed to push blood through the systemic circulation? So, systemic circulation. So, okay, I just want to know what the thought process was when people that picked left ventricle to the aorta.
Just the left ventricle to the aorta and right there.
We're talking about systemic circulation, so it's the whole body. Okay, PAs, it's 1:20 right now. This is the last question. So 1:30, you guys okay to start upstairs? Okay, here's your last one. I'll post the Kahoot in Canvas right after class. Okay, last one. Okay, what's the pressure gradient for the pulmonary system? Okay, right ventricle to that left atrium. Okay, email me questions, Sunday night review, Monday morning test here.
Thank you.
If you want to see who won.